What is a difficult airway? How does one manage it? And how does one evaluate for it? All of these questions are addressed by the American Society of Anesthesiologists Task Force on Management of the Difficult Airway. They define the difficult airway as a clinical situation in which a conventionally trained anesthesiologist experience difficulty with face mask ventilation of the upper airway, difficulty with tracheal intubation, or both. The difficult airway is the interaction of patient factors, clinical setting, and the skills of the practitioner. The task force created the practice guidelines for the management of the difficult airway in 1993 and updated them in 2003 and 2013. They are meant to be used in conjunction with local institutional policies to facilitate the management of the difficult airway and reduce the likelihood of adverse outcomes such as death, brain injury, cardiopulmonary arrest, unnecessary surgical airway, airway trauma, and damage to the teeth. Any of these events can occur when a patient is unable to be intubated and/or ventilated. The guidelines are intended for use for all types of anesthetic care and airway management delivered in all anesthetizing locations. They are intended for all patients of all ages. A difficult airway can be encountered whenever and wherever anesthesia is delivered. You can see at the top of the algorithm they have 4 main points. First, assess the likelihood and clinical impact of basic management problems. They define these problems as difficulty with patient cooperation or consent, difficult mask ventilation, difficult supraglottic airway placement, difficult laryngoscopy, difficult intubation, and difficult surgical airway access. Second, actively pursue opportunities to deliver supplemental oxygen throughout the process of difficult airway management. Third, consider the relative merits and feasibility of basic management choices. These choices are awake intubation versus intubation after induction of general anesthesia, non-invasive techniques versus invasive techniques for the initial approach to intubation, video-assisted laryngoscopy as an initial approach to intubation, and preservation versus ablation of spontaneous ventilation. The fourth point is to develop primary and alternative strategies. After determining that the airway will be difficult to manage and you'll need an awake intubation, you need to decide if you can perform the airway approach that is non-invasive or if you'll need invasive airway access. The non-invasive could mean fiber optic intubation or video-assisted laryngoscopy. The algorithm defines invasive as surgical or percutaneous airway, jet ventilation, or retrograde intubation. If the non-invasive approach fails, you have to consider an invasive one or canceling the case. We already talked a little bit about awake fiber optic equipment. We'll go over the rest of the plan now. First, prepare a primary plan and alternative strategies. Communicate the plan with the anesthesia and surgical teams and make sure you have help available. Then you make sure all of your equipment and sedation are ready. Next, you'll need to make sure that your patient is on board with the plan. Most people can be pretty reasonable when you explain how important it is to manage their airway awake for their safety. Administer Robenal and prep the airway like we talked about in the last lecture. Once in the operating room, positioning is important. I like to have the patient on the OR table with the back up so that they're sitting and I am standing facing them. The patient should be receiving supplemental oxygen via nasal cannula or some other way, and all drugs should be ready to go for sedation and for induction once the tube's in place. At this point, it's time to localize the trachea and give sedation if you haven't already done so in same-day surgery. Remember to be judicious and keep the patient breathing. If you talk to them the whole time and tell them what you're doing, they usually cooperate better. Once the tube is in, confirm with end-tidal CO2 and breath sounds and give your induction agents. If you decide that it's safe to intubate after induction, you still need to have a plan and know what to do if that plan does not work. Pre-oxygenate the patient with 100% O2 for 3 minutes or 4 vital capacity breaths. After induction, if you're not doing a rapid sequence, check for adequate ventilation. Is the chest rising? Do you have end-tidal CO2? Are you maintaining your SATs? Or can you hear obvious signs of obstruction? If you can't intubate with your initial attempts and you're not able to ventilate, you'll start to see hemodynamic changes due to hypoxemia and hypercarbia. Initially, you'll have hypertension, tachycardia, and arrhythmias. This will change to bradycardia, and you could be in a code situation. Call for help early. You may need hands to monitor and treat vital signs while you're trying to secure the airway. There are 2 types of airways that we will deal with: can't intubate but can ventilate, or can't intubate and can't ventilate. If face mask ventilation is adequate, consider alternative approaches to intubation. If you're still unsuccessful, consider using an LMA or waking the patient up. If you ever lose the ability to ventilate, you switch to another pathway in the algorithm. Attempt to ventilate with a supraglottic airway, and if that is not adequate, you move to the emergency airway and you should consider the need for an invasive airway access. We'll be going over the algorithm in the sim lab on Monday, and each student will be presented with their own situation to work through on the SimMan. Some of the non-invasive alternative approaches to intubation include video-assisted laryngoscopy, intubating stylettes, supraglottic airways for ventilation or intubation, fiber optic intubations, and lighted stylettes or light wands. Invasive interventions include cricothyrotomy, jet ventilation, and retrograde intubation according to the algorithm. The latter has really fallen out of favor in actual practice. There are two techniques for performing a cricothyrotomy, the surgical and the Seldinger. Equipment for both are in the tray. This is a YouTube link video for a surgical technique. This is the one we'll review at the workshop. The steps for the surgical technique are as follows. First, identify the cricothyroid membrane between the cricoid and thyroid cartilages. Firmly immobilize the larynx and make a vertical midline incision down to the depth of the laryngeal structures. Make a horizontal membrane incision near the inferior edge of the cricothyroid membrane. The index finger may be moved aside or may remain in the wound, palpating the inferior edge of the thyroid cartilage to guide the scalpel to the membrane. A low cricothyroid incision avoids the superior cricothyroid vessels, which run transversely near the top of the membrane. Insert the tracheal hook, oriented transversely. After insertion, apply cephalad traction to the inferior margin of the thyroid cartilage. Insert the trocodilator a short distance into the incision and enlarge the opening vertically. Insert the cuffed emergency airway access assembly between the blades of the trocodilator into the airway. As the assembly passes between the blades, rotate the trocodilator 90 degrees counterclockwise, orienting the blades longitudinally into the airway to facilitate passage of the airway assembly. Fully insert the cuffed emergency airway access assembly and remove the instruments. You can inflate the cuff with the syringe about 8 to 10 mLs. Connect the emergency airway catheter to either an ambu bag or your machine. Check for positioning, listening to breath sounds and looking for entitled CO2, and then fix the emergency catheter into place with the tracheostomy tape. That is the end of Lecture 3. There is one more short lecture on extubation and endotracheal tube exchangers.